Good morning, and thank you for asking me to give this talk. The task assigned to me is Evolving Paradigms in the Management of Barrett's Esophagus, 25 years in making. Just to point out that when somebody is asked to give a talk on something that is evolving over 25 years, it usually means that you're officially getting into the senior citizen category. So thank you, Alia. But let's get back to the task. These are my disclosures. None of them are relevant to the present talk. But first, let's start. Why this talk? Why are we talking about Barrett's esophagus and what has changed in 25 years? Let us imagine that this blue square is the entire population of the United States. This is the person, or about 30 to 35% of the patients who have symptomatic reflux disease. This tiny proportion of patients are the one that we are trying to avoid, the esophageal adenocarcinoma, the fastest growing cancer in America, and so forth. However, if we go ask the patients with esophageal adenocarcinoma, only about 60% of patients give a history of reflux disease. Meaning, if we concentrated only on patients with reflux disease, we can at best hope to catch only 60% of patients who ultimately develop esophageal adenocarcinoma. But let's leave that discussion for another forum. This is let us say, the proportion of patients with known Barrett's esophagus. Majority of them have reflux disease. Some of them are picked up during screening for non-reflux reasons or endoscopy for non-reflux reasons. And you can notice that only a small proportion of patients who have known Barrett's esophagus, actually less than 1 to 5% of patients actually go into esophageal adenocarcinoma, and put in the reverse way, less than 5% of esophageal adenocarcinoma patients presently have a history of known Barrett's esophagus. So we have a long way to go in figuring out that whether all Barrett's esophagus, how to identify them. And this probably is the proportion of all the Barrett's esophagus patients. And this slide assumes that all esophageal cancer patients have a stage of Barrett's esophagus that can potentially be detected and intervened on, but we know for sure, we don't know that for sure. So, but for the sake of this discussion, let's assume that this are hypothetically all the Barrett's esophagus patients in the population. All the esophageal adenocarcinoma are only a subset of the same. With this background, let us just go over what I am going to discuss. I'm going to discuss that can we identify the population that has risk of developing Barrett's esophagus even if they don't have symptoms? Can we identify the Barrett's esophagus that is not at a risk of progression, so we can concentrate on the patients that are at risk of progression? Do we have less invasive and cheaper technology for screening and surveillance? What can we do to halt the progression? And is there any radical treatment for Barrett's or high-grade dysplasia or cancer than esophagectomy? As you just saw, that this slide was from 2004, and I'm going to give it a scorecard or a grade at the end of my presentation where we are in 2020. Now, the two things before I get started on the other stuff is the two things we were 100% sure of in 1995, that we knew what Barrett's esophagus was. It was 3 centimeters of columnar metaplasia with intestinalization in the distal esophagus. And we knew that the Barrett's came from the migration of gastric epithelium towards the esophagus. However, is that still the case? Well, we uniformly agree that Barrett's esophagus is the replaced metaplastic columnar mucosa. However, do we require a pathology of confirmation? If you're in England, just an endoscopic appearance of columnar mucosa is enough to diagnose you at Barrett's esophagus. In rest of the Europe, you need a pathological confirmation. If you go across the pond, in America, an intestinal metaplasia or goblet cell presence is required in most places, though it has been questioned whether it is actually needed or not. What about the length of the replacement? In 1995, we were sure that more than 3 centimeters of columnar metaplasia with intestinalization is Barrett's esophagus. Then came the lo behold that even less than 3 centimeters of mucosa, which has been replaced, and we started calling it short segment Barrett's. Slowly and slowly, we decreased the length of the requirement that any visible changes in endoscopy, which on biopsy has columnar metaplasia with IM, is called Barrett's esophagus. Till recently, just about 2 years ago, rather than decreasing the length, the gastroenterology societies have recommended that you should be at least 1 centimeter of length, which on biopsy has the columnar metaplasia with goblet cells. However, does it really make physiological or pathophysiological sense? What about cardiac intestinal metaplasia? It is the same pathophysiology. Yes, the risk may be lower, but it's not zero of progression to esophageal adenocarcinoma. So I think we are a way away from having a universally accepted definition of Barrett's esophagus. We may say that this Barrett's is at less risk of progression. Again, that's the next part of the talk. In 1995, we were sure that the damaged esophageal mucosa from reflux was replaced by migrating cells from the stomach. And we were sure about where the Barrett's came from. However, since then, studies have shown that the actual cell, the columnar metaplasia or the goblet cells, may come from either a dedifferentiation or a concomitant differentiation, colonization, or colonization from circulating stem cells, or the luminal unfolding. Essentially, we still don't know for sure where in a particular patient the cell of origin for Barrett's esophagus comes. And we need to make progress on that, whether it is same in all patients or whether it is different in different group of patients based on history and so forth. But if we have patients with Barrett's esophagus, these are our current screening and surveillance guidelines from the major gastroenterology and ACP organizations. Basically, endoscopy is not indicated for the general population or even for vast majority of patients with reflux symptoms, only if you are an older person with multiple risk factors or alarm symptoms, and also for patients then for surveillance only for dysplasia, depending on how much dysplasia you have, how frequently it is. But these are not really accurate in my opinion. These are the current state of the guidelines from Bobcat and put forth by International Society of Disease of the Esophagus. I think one of the first statements says screening and surveillance of Barrett's esophagus do not decrease mortality from esophageal adenocarcinoma or overall mortality. Having gotten that out of the way, let's talk about who we should screen. The Bobcat guidelines say that we should screen somebody with more than 5 years of reflux history, preferably more than 10 years, with 2 or more risk factors. And the risk factors are a Caucasian, the male gender, having a central obesity, being an older gentleman, more than 50 years of age, preferably more than 60, and or a family history of Barrett's esophagus and esophageal adenocarcinoma. They further go on to say that if you do not have Barrett's esophagus at baseline, you do not need any follow-up endoscopy to look for Barrett's esophagus unless alarm symptoms develop. However, they did say that if you have severe esophagitis at baseline, then you need to repeat an endoscopy on PPI therapy in 10 to 12 weeks. However, not developing Barrett's on treatment if you don't have Barrett's at baseline has been questioned. This is a paper from 2000 that showed that out of 166 patients who did not have Barrett's at baseline, they developed intestinal metaplasia during the study period of 10 years. About 12% of patients developed Barrett's esophagus in 10 years of follow-up. Another 2 studies, one larger and one smaller, showed that 10% of people who did not have Barrett's esophagus at baseline developed Barrett's esophagus at 5 years, and up to 25% of patients develop Barrett's esophagus in 10 years. I know that this number is quite small, but it's while concerning that 1 out of 4 people who did not have a pre-malignant lesion on our watch, on our current management strategy, develop a pre-malignant lesion. Well, let's forget about that, whether we should screen again or not. But how should we screen? At present, the standard is a sedated, white light, high definition endoscopy, and addition of narrowband imaging is recommended. However, this requires sedation, is expensive, and high technical skill. So an alternative transnasal unsedated office-based endoscopy has been proposed. However, this has not really caught on the imagination of the gastroenterologists, or more likely the primary care physicians, as I thought that it would. There are some non-endoscopic methods to screen with and without cell collection options, and non-esophageal methods that I'll discuss going forward. The non-endoscopic methods are that there is no cell collection, which is a visualizing camera, and it may be attached to a string that allow us to look repeatedly at the GE junction in the area of concern, versus a double-facing camera or the PillCam ESO2, which is dependent on the transit time to allow us to visualize and the number of pictures. The one with the string appears to be better for screening. For the non-endoscopic cell collection methods, there is a cytosponge, which is a capsule that you swallow attached to a string. The capsule dissolves, and the sponge, which is quite abrasive, is brushed against the distal esophagus, collecting the cells, and then it is pulled out of the mouth and examined. There is another option, which is called the EsoCheck, which is a capsule-shaped device that you swallow. Once you have swallowed and it's in the stomach, you inflate, and this balloon comes out, and the balloon has some of these abrasive spikes. You pull it through the esophagus, and then you suck it back in, protecting the specimen before you pull it out of the mouth. The cells or the cytology material can either be assessed for histology, but more commonly it is subjected to molecular markers such as TEF3 and methylated DNA to look for presence of Barrett's esophagus, and then a subsequent endoscopy is recommended for those patients in which it is detected. These are the non-esophageal methods. There is the blood-based, serum-based miRNA level or cell-free DNA level, a breath test for volatile aromatics, and a fecal DNA test. However, all these have been developed or tested basically in esophageal adenocarcinoma patients, and I'm not sure what their utility is for the general population with and without reflux for screening of Barrett's esophagus. Someday we may have one, but not at present. Well, let's say we have screened a person. What should we do about surveillance? At present, it is recommended that if you have non-dysplastic Barrett's, then you repeat an endoscopy in 1 year and then every 3 to 5 years. If you have low-grade or indefinite dysplasia, then you require 2 pathologist confirmation and then a surveillance every 6 months. On the other side, it is increasingly being recommended to go for ablation or eradication therapy if you have low-grade dysplasia. If you have high-grade dysplasia, I think it is standard to go for ablation or eradication. If not, for some reason, then we go for every 3-month surveillance. However, even if you go for ablation or eradication, every 3 months biopsies are indicated. So whether you call it a follow-up after ablation or you call up surveillance, it is the same endoscopic protocol. If you are doing a surveillance, how should you do it? The surveillance, the standard is a white light, high definition endoscopy with addition of narrowband imaging is helpful according to some people. The OCT technology is very promising, and there are 2 options, confocal and VLE. One of these have been temporarily withdrawn from the market. Both of them are very time consuming and require a high degree of expertise, and hence not yet caught the imagination of general surveillance. The biopsy protocol, the Seattle protocol, is every 2 centimeter 4 quadrants, and any visible lesions that are either biopsied or more recently EMR'd have been the standard. However, a Watts, which is a brush that samples a majority of the esophagus and subjected to cytology type assessment using artificial intelligence and 3D surveillance technology, is able to, it looks very promising to find out dysplasia in these patients. However, we still don't know whether surveillance is effective or not, and there is currently a BOSS trial going on in England, the results of which are eagerly awaited and will be available in another 5 or 6 years. Can we predict the progression of Barrett's esophagus? At present, the best guidelines are patients with dysplasia, low-grade, indefinite, or high-grade dysplasia before progression to cancer. Molecular markers such as tetraploidy, P16 or P53 have been shown. There is less talk of these technology now than were there in 2000, but I think they're still important. The technology such as NBI, confocal endoscopy, or Watts can be used to predict progression, but really they are not predicting progression, but picking up disease that has already progressed, albeit earlier than we would have with the current biopsy protocol. So it's not predicting progression, but just picking up progression sooner, which is good. What about halting the progression? Can we halt the progression of Barrett's into esophageal adenocarcinoma? Various studies have been done, And a cocktail of aspirin with COX-2 inhibitors or PPIs, specifically high-dose PPIs, or the statins have been used with varying success for prevention of progression to adenocarcinoma from Barrett's, but we still have a long way to go to know exactly what we should. But taking an aspirin a day and a statin a day probably does help your heart. So nothing wrong about that if you can tolerate the side effects. I think we are very good at halting progression for dysplastic and removing the dysplastic Barrett's. We call it eradication of Barrett's esophagus. Traditionally, we had the laser and the ZAP, respectively, the YAG laser and the photodynamic treatment. More commonly, it is Barretts, which is a radiofrequency burn, and a cryofreeze with nitrogen gas, with the liquid nitrogen. They are more commonly used now. There is a new kit on the block in which you vaporize or you steam, a steam-based ablation. It's called Aqua. This was presented at the UES last year, and we expect it to be available in the US in near future. Then obviously we have much better technology for endoscopic mucosal resections and endoscopic submucosal dissection, which are becoming much more widely prevalent with better technology. But where do we stand today? You remember all the points that we discussed. I think if I look at from the bottom going upwards, I think in terms of intervention to halt progression, but rather actually ablate dysplastic Barrett's to prevent from going from cancer, and hence less radical treatment esophagectomy, we are doing very well. We have multiple options. We do a very good job, and I would give ourselves a pat on the back, and we are at probably an A+ grade. However, the other options, which is an improved molecular marker of progression, or the less invasive and cheaper technology, I think we have ways to go, but I would still give us a passing grade, maybe a C+ or a B-, and that is being generous. But on the other points, such as identifying the patients who should be screened with or without symptoms, identifying the Barrett's who are not at risk of progression so we can exclude them from follow-up surveillance. What is the definition of Barrett's esophagus? What is the original cell of origin for Barrett's esophagus? I think we are clearly failing in this, if even believe that we have taken the exam. In some of these parts, we are not even making an attempt to proceed in getting an answer. So in sum all, to really make a difference, we have a long way to go. We have progressed a lot in taking care of Barrett's once we know that it is bad and turning to cancer, but we have a long way to go. And thank you. And with a promise, I look forward to the other talks. Thank you.